time for the talk. So traumatic brain injury, certainly it's defined as an insult to the brain from an external mechanical force. I think we know that. It's a pretty common problem. There's 1.7 million people in the country that have this every year. It kills 52,000 of us, and it's a contributing factor to nearly a third of all trauma-related deaths. There's about 300,000 hospital admissions. You'll notice one of the most common causes is actually falls. So we fall down a lot, and that's probably one of the most common things. And it's a leading cause of death and disability in young people. So if you're 44 and under, this is the leading cause of death and disability for your age group. The brain requires, it's pretty simple, the brain requires oxygen, glucose, and then it actually needs perfusion. Perfusion brings oxygen to the brain, brings glucose to the brain, and it carries wastes away. And so those three things are needed by the brain. All of the things that we do as neurosurgeons really are pretty simple. It's not terribly complex, but it's managing what's going on inside the cranial vault. And it's the management of intracranial pressure that is the goal of the neurosurgeon, roughly. And you basically can, since the head is a closed box, I think most of us understand this concept, you can have certain things in that box, namely brain, spinal fluid, and blood. And so when you acquire something other than those three things, then something else has to give. One of the other compartments has to give way so that you don't actually damage the brain, and the brain doesn't squirt out through the holes in the bottom of the head, which is a terminal event. And so much of neurosurgery is dedicated to managing intracranial pressure and these volumes that are found within the head. Primary brain injury, all of us really have a responsibility for trying to have an impact on this, from helmet laws, bicycle helmets, that kind of thing, avoiding drinking and driving. All of these things can help decrease primary brain injury. The neurosurgeon per se and the nurses that care for the patients don't have any special role to play in intervening with primary brain injury, because this occurs before the patient gets to the hospital. We certainly can be advocates for helmet laws and that kind of thing, but we don't have any special tools that any of the rest of us don't have. Secondary brain injury is what we concern ourselves with. Following the primary injury to the brain, it's the secondary injury that physicians, nurses, therapists all intervene in to try to prevent. And the things that the brain does not like is hypoxia, which is low oxygen, hypotension, which is low blood pressure, increased intracranial pressure, disturbances in glucose, either too high or too low or bad, metabolic disturbances, and seizures should all be avoided. So why were the guidelines developed? You know, one of the big reasons, there was a tremendous difference between hospitals as to how they care for the patient with traumatic brain injury. The point of the guidelines was to try to reduce that heterogeneity that exists between different institutions. And what has happened as a result of the guidelines is that we've reduced costs, decreased mortality, and increased favorable outcomes for these patients. And it's been a joint project by both the AANS and the CNS, which are our parent organizations within the country, as well as the Brain Trauma Foundation, and then the section on neurotrauma and critical care. There have been 3 iterations of the guidelines for traumatic brain injury. The first was in '95, the second in 2000, and the last was in 2007, and that's what we're talking about today. Strangely, actually, the next set of guidelines is due shortly. They try to revise these now on a 5-year cycle. I don't know if they're going to make it out with the 2012 edition, but we anticipate in the next year or two that they will update the guidelines. So the guidelines focus on classes of evidence, and the evidences can be classified as Class 1, Class 2, and Class 3. Class 1 is the highest randomized controlled trials that are excellently performed. Very difficult to get that kind of data within medicine today, and I'll point some of that out in the upcoming talk. Class 2 data falls under those categories. I don't think we really need to dwell on it. Class 3 is more retrospective, poorly controlled trials, case series, and that's where Class 3 data comes. And as a result of this kind of data, we generate recommendations within the guidelines that are level 1, level 2, and level 3. These level of guidelines don't necessarily correlate directly with the class of evidence, but when there is a large amount of Class 1 evidence, then a level 1 recommendation might be made. So let's get right to the guidelines now after 10 minutes have been wasted on introductions. The blood pressure in the patient with moderate to severe head injury should be kept with a systolic blood pressure above 90. And so it's interesting because the mean arterial pressure is actually more useful to us in that it is the mean arterial pressure and the intracranial pressure that we use to calculate CPP, which is cerebral perfusion pressure. I know y'all are like glassing over. So it's interesting because nurses and physicians seem to be so interested in MAP, but no one has been able to come up with a guideline concerning MAP. And so with regard to guidelines development, the studies all have all used systolic blood pressure. A level 3 recommendation is to avoid hypoxia. That seems pretty obvious. This is interesting, and I want to point this out to you. We're not going to generate level 1 data on oxygen. That would require us taking patients and enrolling them in a trial whereby we're going to starve a certain group of patients of oxygen, and another group of patients we will work to maintain normal oxygen status. So because we can't do a trial like that, you will never get level 1 data on the role of oxygen in the management of hypoxemia in head injury. So just because it's a level 3 recommendation doesn't mean that it's not important. It just means that's the best we can do. We're not going to randomize patients to hypoxia. That would not be good, and even Kara, our medical ethicist, would probably be frustrated by such a trial. Anyway, hyperosmolar therapy, mannitol is a level 2 recommendation, and it's useful for controlling increases in intracranial pressure, and naturally you should avoid arterial hypotension. A level 3 recommendation is to avoid the use of mannitol except in the patients that you're not monitoring their intracranial pressure. There actually were a large number of centers before the guidelines came out where the neurosurgeons and the nurses would give mannitol to patients without ICP monitors in. So if they had head injuries, they would just give the drug, but they didn't know what they were treating. And so there's a level 3 recommendation actually to avoid mannitol in patients that don't have ICP monitors, except when they present to the hospital with signs of transinterior herniation or neurological deterioration prior to placement of the monitor. So it's fine in the ER to give mannitol, but let's not admit the patient to the ICU and write a standing mannitol order unless we're going to put in an ICP monitor. And that probably shocks some of the people here, but there were places that were doing that. they were just giving mannitol, but they had no idea what they were doing. And so now it's in the guidelines. It's effective. Mannitol lowers, transiently lowers ICP, there is a ton of interest now in hypertonic saline. Hypertonic saline can also decrease the intracranial pressure in those patients who are refractory to mannitol. I would suspect that the next guidelines that comes out, there may be some data that supports or will lead to at least a level 3 or level 2 recommendation for hypertonic saline. But currently, hypertonic saline is not part of the current guidelines. Prophylactic hypothermia recommendations. So this is an area of really great interest. Prophylactic hypothermia in general has not been shown to decrease mortality when compared with normothermic controls. However, the data does suggest that there may be a decrease in mortality in those patients who are treated with prophylactic hypothermia who are treated for greater than 48 hours. This is another area of interest that, again, will probably be revised in the next guidelines. Prophylactic hypothermia is associated with a significantly higher Glasgow outcome score when compared to scores from normothermic controls. So that is a true statement, but yet we don't really have solid data to give this a recommendation beyond level 3. And it's, again, probably going to be sorted out in the next set of guidelines. Really, probably the best trial on hypothermia was released by Guy Clifton down in Houston, where I trained in '93. And there's no difference in mortality, but look at the second check mark. There was at 3 months, the good recovery rate to moderate disability was 52% in the hypothermia group and only 36% in the normothermia group. So the patients that were treated in this large study had a better Glasgow outcome score at 3 months if they were treated with hypothermia. But again, this has not been studied well enough to know if that's really a true finding that can lead to a level 2 recommendation. Go ahead.
What are you defining as hypothermia?
32 to 33 degrees Celsius. So there are all kinds of things. Target temperature, when do you cool the patient, how long do you cool the patient, how quickly do you rewarm the patient. And these are the questions that need to be answered to generate a higher level recommendation. And I think, to be honest, I think as ICU nurses, you already have a lot of experience with hypothermia in cardiac arrest patients. I think we as neurosurgeons probably in the coming years are definitely going to be changing the way we manage traumatic brain injury. As you recall, last year I spoke about hypothermia and spinal cord injury, and that too is an area of great interest, but today we're talking about traumatic brain injury. We do know that hypothermia does help control seizures in the head injured patients. Infection prophylaxis guidelines. So if you're going to intubate a patient, it would be reasonable to give them a pre-intubation dose of ANSEF because that does decrease the incidence of pneumonia. But putting them on ANSEF after they're intubated does not decrease hospital-acquired pneumonia and probably shouldn't be done. Of more interest in particular to the neurosurgeon, changing ventricular catheters routinely or prophylactically is not recommended. And in fact, the use of antibiotic therapy is a level 3 recommendation for ventriculostomy management, but that probably is not recommended either. It really doesn't do any good to keep a patient on ANSEF just because they have an ICP monitor in or ventriculostomy. This is how I was trained. We always did it, and it doesn't help. It just selects for resistant organisms in the CSF. The use of antibiotic-coated catheters for ICP management is an area of real interest. And the trials do show that antibiotic-coated catheters do very significantly decrease the rate of CSF or catheter colonization. And when the isolates are tested in those trials, they many times are still susceptible to minocycline, which is one of the common antibiotics. But there is a tendency towards some rifampin resistant in those isolates when they do get infected. And minocycline and rifampin are the two antibiotics put on the antibiotic-coated catheters. And so those have not yet been studied enough to reach the guidelines, but it is something to keep in mind. DVT prophylaxis. I think that this has also been an area of interest among physicians lately, and in fact, neurosurgeons need to use it. Both mechanical and pharmacologic DVT prophylaxis is recommended. However, patients that do receive pharmacologic DVT prophylaxis, they do have a tendency for an increased risk of expansion of their intracranial hemorrhages. And so the timing, the dosage, none of that has been really worked out. When do you start DVT prophylaxis? That is not part of the guidelines currently. And that's really going to be practitioner dependent. But the point is that we all need to keep this in mind, and even patients with blood in the head do need to have DVT prophylaxis. Indications for intracranial pressure monitoring. I think all of the surgeons at VNA basically subscribe to these categories. So if you have a bad head injury, a GCS of 3 to 8, and an abnormal scan, you're going to get a ventric. If you present to the hospital and you're comatose, and you have a normal CT scan, and then 2 or more of the following features: either you're over 40, you have unilateral, bilateral motor posturing, or systolic blood pressure less than 90. I think among the VNA surgeons, all of these patients would get an ICP monitor. The study by Narayan in 1982 showed that patients who meet the 2 of these criteria, have a normal scan, and then had an ICP monitor placed, had ICP problems that were similar to those with abnormal scans. In other words, a normal CT scan doesn't mean you have normal ICP. You can't transduce someone's intracranial pressure from a CT scan. It's a picture. And so patients who are sick, regardless of their scan, are going to get ventriculostomies. And I think everyone at VNA subscribes to this. And that's basically what this slide shows here. And then again, here's another statement: not monitoring the ICP while treating for elevated ICP can be bad and result in a poor outcome. So don't do that. I mentioned that earlier. We don't really need to talk about the types of technologies. Basically, the point of this slide is the most reliable is a ventriculostomy catheter. Probably in the future, our ventriculostomy catheters we will continue to use those with a direct fluid coupling to the transducer at the bedside, but they're probably going to start putting strain gauges in the wall of the catheters so you can directly measure the ICP from a transducer in the wall of the catheter in time as that technology improves. And it's an area of really dramatic interest because all of the data, or generally most of the data, comes from knowing what the ventricular ICP is. But what we don't know is should we monitor parenchymal values near areas of contusions or hematomas? Because ICP is a global number, we just look at that one number. Well, that doesn't necessarily tell us what's going on in each compartment of the brain. And so an area of research is trying to figure out, should we be monitoring ICP near the area of the actual injury itself? And it's one of those things that's hard to figure out, basically. This talks about some of the future monitoring technology. What are the thresholds for ICP? We typically use 20, which is level 2 recommendation. But again, the need for treatment is a medical decision that's made on the basis of the patient's clinical situation, their CT scan findings, and the number. So you can't treat just a number alone. You have to treat the whole patient, and this is why it requires a team of both nurses and physicians caring for these patients. Cerebral perfusion thresholds. This was actually a study that came out of Baylor, where I trained in Houston. Claudia Robertson's study showed that there shouldn't be an aggressive attempt to maintain CPP. The level 2 recommendation is that when you try to do this by driving their blood pressure with vasopressors and fluids, and you increase dramatically the chance that you're going to put them into pulmonary distress, and outcomes were not improved in those patients. A level 3 recommendation is try to avoid a CPP below 50. The actual threshold we don't know. It's probably good to keep CPP above 60, but the guidelines just says, look, just avoid everything below 50. So we know 50 really is a legitimate lower threshold of what's reasonable. That's a number that's important for all of us to know that care for these patients. So that's probably a take-home message. Brain oxygen monitoring and thresholds. This is another area of really dramatic interest in new research. We don't currently, in our ICUs or hospitals, measure jugular venous saturation or brain oxygen levels. To measure the brain's oxygen level, you have to drill a burr hole and put an oxygen, basically it's a little optical oxygen monitor into the brain itself. To do SJVO2 monitoring, you have to do a reverse central venous catheter, so it requires a stick in the neck, and you feed a catheter right up to the jugular bulb. And we did this where I trained in all severely head-injured patients, and there's not currently anything beyond the level 3 recommendation. We did these numbers, and you should try to avoid an SJVO2 DSAT below 50, because we know that increases mortality, increases bad outcomes, but we really don't know what to do with the number for sure. Right now, no one really knows how to treat it. All we know is that if you do DSAT, if your jugular venous oxygen saturation drops dramatically, well, that means that the chance of you having a bad outcome is higher, but we don't really know what to do to act on that number, and that's trying to be, they're trying to sort that out currently. I think that in the future, probably in the serious head-injured patients, it will be much more commonplace for them to have an ICP monitor and probably an SJVO2 monitor placed. I'm not sure if we're going to start drilling holes and putting brain tissue oxygen monitors in, but that is another piece of data you can get. Any questions? The anesthetics, analgesics, and sedatives. There are some neurosurgeons who used to give barbs to patients prophylactically, and none of us do that at VNA, and that's really not to be recommended. You can give barbs to lower ICP in patients that are refractory to all other forms of ICP management. That is a level 2 recommendation, so that's good. We know propofol does lower ICP, but there is no evidence yet that it improves mortality or 6-month outcome. So you can use propofol in place of barbs to lower ICP, but no one's been able to show that it leads to improved outcomes. But it's something you can do. You have to be careful about propofol infusion syndrome. Propofol can make patients sick. They get metabolic acidosis and a dramatic increase in their triglycerides if you leave them on it for too long. Nutrition recommendations: feed the patients. Don't let them starve. That's a level 2. That's another thing that you're not going to get a level 1 recommendation on. And the highest you're going to get is level 2. So you need to start trying to feed them as soon as possible. And the goal is by 7 days after they've been in the hospital a week, they need to be on full caloric replacement, usually plus 20%. So I don't know if we have any nutritionists or dietitians in the room, but this is something that they help us out with in the hospital. And they usually make sure this gets done along with the nurses. So, seizure prophylaxis, Dilantin is actually the drug that's been studied. There's a level 2 recommendation to use Dilantin for only 7 days. There's no benefit to leaving someone on Dilantin for 8 days. It's 7. That's recommendation. It's a level 2 recommendation. It helps prevent early post-traumatic seizures. It does nothing to prevent late post-traumatic seizures. No evidence to support using it beyond 7 days. If someone has a seizure at 10 days after a head injury, load them with Dilantin and call neurology, because neurology is going to need to manage that patient like any other patient with epilepsy or seizures. Dilantin prophylaxis for 7 days. Again, no reason to go beyond that. This is actually an area of interest in a large brain tumor study that just came out, I think in the spring, out of MD Anderson, a place that I also trained. They have gone away from Dilantin prophylaxis in brain tumor patients because of the cost and the risk to the patient was greater using Dilantin prophylaxis, and a drug like Keppra is probably going to be ultimately recommended because it has a better side effect profile, although it's much more expensive. And it wouldn't surprise me in the future if the head injury guidelines end up changing and we switch over to a drug like Keppra. The goal is to avoid liver toxicity in Stevens-Johnson's syndrome. I've never seen it, but it's apparently horrible. Hyperventilation, level 2 recommendation, don't do it. Getting a PaCO2 of 25 is not recommended. And you can use it as a level 3 recommendation as just a temporizing measure to reduce ICP when you particularly need it, but try to avoid it within the first 24 hours after the injury. If you're going to use hyperventilation, then you probably should put an SJVO2 monitor in. Blowing someone down to a PCO2 of, say, 35, 36, 37 isn't really considered hyperventilation per se. It's when you start going below that's considered hyperventilation. So if the physician wants to really hyperventilate the head injured patient, he probably should put an SJVO2 catheter in. Steroids, don't give them. They don't work, they hurt the patient. I'm still amazed when people call from the ER or somewhere and you have a head injured patient, they want to give steroids, or someone with a bleed in the brain, they want to give steroids. There's no evidence to support it. The management of traumatic brain injury, there's actually guidelines, strangely, for this. It's a separate part of the book. Intracranial hematomas and mass lesions occur in a fair number of people with severe traumatic brain injuries. They almost never occur in mild traumatic brain injury. The guidelines here actually talk about the indications for epidural hematomas. I didn't actually know these existed. This is what neurosurgeons do when they're in the ER, where they're trying to figure out, should I operate, should I not operate? And, but there's actually someone who's trying to formalize this. I don't know if my partners do these guidelines or not, but based on the size of that epidural hematoma, there are actually suggestions for what you should do. Strangely, in all of our training, this is how we're trained, and we make these decisions all the time, but there is actually someone trying to put a number to things and figuring out when or you should or shouldn't do surgery. People are trying to figure out, is it better to go to someone that can manage epidural directly, or is it bad to be transferred to someone later that hasn't been formally studied? Although there's a lot of evidence that transferring patients with epidurals is bad, and that's why we believe that the neurosurgeons in our group should be able to take care of these patients. There's a recent push by the state of Colorado to basically start shipping all of these patients to Denver. I don't know if you're aware of that, but we have vigorously opposed it because it dramatically increases the amount of time before the craniotomy is done. It seems like that has gone away, hasn't it, Kara?
Well, I mean, at this point in time, there are recommendations for scopes of care, so it's definitely not completely off the table. We have to keep our eye on it, but they did back off a little bit.
Yeah, it's amazing. I couldn't believe they were doing this. They wanted to transfer patients with intracranial hematomas all to Denver and ship them out of our hospitals when we can take care of them. And so anyway, acute subdural hematomas, there's actually indications for surgery. We don't have to go over these. Traumatic parenchymal lesions, posterior fossa mass lesions, depressed cranial fractures. Pediatric guidelines, there's actually I'll just mention two things. In the pediatric guidelines, hypertonic saline gets a little more attention, and I think it's a level 2 or a level 3 recommendation. And moderate hypothermia in kids within 8 hours and for up to 48 hours should be considered. So it's a level 2 recommendation in kids for hypothermia. These are people 14 years of age or under.